everybody. Welcome to the Bertec Knowledge Series. Thank you for joining us today. I'm sure you're all having a busy week. We're excited to have you here. I hope it's beautiful out where you are. It's a gorgeous day here, so I hope you're enjoying some of the same weather. Hi, Dr. Santos. Hi, Dr. Shearer. Welcome back.
Hello.
We're excited to have you. We are recording this webinar, as we always do, to post on our YouTube channel. So if you haven't checked it out before, we have a nice library growing of all these webinars. And if you ever miss any parts or you miss a full webinar that you wanted to catch, you can join us there and subscribe so you don't miss any. Today, we're very excited to have, for our topic, what are we calling it? Eye movement and VOR therapy from an eye doctor's point of view. We have Dr. Charles Shearer joining us again. He's a neuro-optometrist with his own practice in Indiana. He specializes in vision therapy, pediatric vision, visually related learning problems, and sports vision enhancement. And he's someone who always has had one foot in product development, the other in clinical practice, which is a really cool perspective. So he brings his vast clinical experience to the innovation of new and useful products for companies like Bertec. We love having him host webinars for us because he's someone who truly cares about the multidisciplinary approach we're trying to achieve in this series by bringing together leaders in movement sciences to share their best practices and explore new research for clinical application. So we're excited to have him back, and we'll continue to have him back for interesting talks like this. And then, of course, we have Dr. Fernando Santos, who has his PhD in biomechanics and movement sciences. He's an accomplished physical therapist and PhD who worked with Paralympic athletes and people with balance impairments in his own clinic. He's a senior applied biomechanist with Bertec and my partner in creating this webinar series. So welcome back, Fernando. And my name is Alyssa Heine. I forgot to introduce myself last time. I work in knowledge management and learning development here at Bertec, and we're excited to be back. So with that, just a quick rundown on the format once again. We're going to play his pre-recorded presentation. And during the presentation, while we're doing the playback, please feel free to enter your questions in the chat. And we can't turn off on our cameras or unmute ourselves as participants in the webinar series. So please, any questions that come up, we can actually address during the presentation. And this one runs about 26 minutes long. So we'll also have time to answer questions after the pre-recording is over. So with that, did I forget anything? I'm going to go ahead and play the recording.
Good afternoon. This is Charles Shearer. I'm a neuro-optometrist consulting for Bertec. I'd like to welcome you back to, this would be the third webinar that we've done on vision, and I appreciate all the questions and kind comments that we've gotten. Welcome to today's presentation. It's on vision, vestibular, and eye movements, basically all about VOR from an eye doctor's perspective. We take things at a little different perspective than the OT and PT might, with a little more emphasis, obviously, on the vision part. For us, we want today to kind of teach you what we think is the logical progression of eye movements, and then review the H pattern that we all are used to when we test eye movements, and understand the importance of target size, and we'll introduce you to the concept of binocular vision targets. And then we'll discuss the three eyes. Everything starts with steady fixation and visual attention. Post-concussion, post-stroke, a lot of patients will just be unable to hold steady fixation or hold attention. So we want to evaluate that and train that before we start moving the eyes. And then once we start working on eye movements, we want to first work on saccadic eye movements and then on the tracking eye movements. And then we'll discuss what happens when we introduce vestibular stimulation. And then from there, of course, we get into the both vestibular and muscles in the neck. And then finally, we want to put it all together. To start with, fixation is very important. And the first thing we're going to do is just evaluate that in a straight ahead or primary gaze. So we just want them looking at a simple target, seeing can they hold their eye and their fixation on the target and their attention, because there are some cognitive issues in a lot of these cases. Next, we're going to get into just eye movements only, first with tracking, first with saccades and then with tracking. And we'll talk about the different muscles that are active in these different positions of gaze. And we'll talk about vestibular and how that affects and how we want to train just vestibular only. The idea is to identify, isolate, improve, and then integrate all of these systems together. Then we'll get into finally putting the whole shoot and match together. And then it's at this point that most of you will finally feel comfortable, maybe, because we'll be talking about VOR ×1 and VOR ×2. So those are all techniques and things that you're very, very familiar with, of course. First, a little word about targets. I often see when doing a VOR evaluation that the tester will just take out a piece of paper and put a big X on it and use that as a target. And that gives them something to look at, and it's not totally wrong, but we want to control that target a lot more than that, because when you have too big a letter, it just doesn't control their focus well enough. So this is one of those cases where size does matter. The smaller the target, the more exactly they'll hold on to focus. You don't want to make it so demanding, particularly with an older patient, that they're having trouble seeing it or they have to concentrate exclusively on focus, but we want them to have to maintain a very tight focus, because focus affects eye alignment. Every time we focus our eyes, we also cross our eyes. And with the high prevalence of accommodative and convergence insufficiency post-concussion, this becomes rather important. Eye alignment also affects eye movements. If the two eyes aren't teamed together, they can move independently of each other, which it can induce double vision, and they don't know where to go. And then we'll kind of introduce you to the concept of using binocular targets or red-green targets. And I did a little video, a little animation here for you to kind of show this. This is an app I have on my phone. The bigger the target, the less they have to maintain focus. So if we have a real big target, as you saw there, they have to just be within a diopter of focusing power. If we make the target smaller, they have to focus better. As far as visual attention, notice the target on the left is constantly changing. So they would have to keep their attention on that, stay focused on that, possibly even call it out, which would be, of course, dual tasking. And then if we really want to get tricky, then we use a 3D target. Notice the target on the right is red and green. We put on red cyan glasses, and when the glasses are on, they have to keep both eyes turned on, lined up, and working together in order to see these targets. And you can imagine as you're moving those targets around, that becomes even a little more possible, or a little more difficult to do. And that's particularly important with our post-concussion patients because of all the convergence problems. If they were to lose convergence while doing this target, either the N or the H would disappear or the X would double. Step two, we want to do those positions of fixation and all the cardinal positions of gaze. So again, we'll go to this little app here, and we'll do the follow my finger test, which we're all used to doing. Basically, those are the 6 cardinal positions of gaze. So what you're going to do is hold your finger out in front of the patients, have them just fixate on that finger, then move the finger over, have them fixate on that. It would be more accurate to use the same targets that we just talked about, but I wanted to relate this to what you're primarily doing now. So the reason that we use these patterns is because we have a way of evaluating all of the 6 extraocular muscles around the eye, and that's why we use this H pattern. And then step 3, we'll make jump eye movements. We want to just use saccadic eye movements and not head movements at this point. We want to start out simple, very small movements in the central zone and make those movements wider and wider apart. You're going to see a little demo of using the outside edges of this heart chart. For those of you who may not be familiar with what a heart chart is, it is a chart that we use for often for accommodation or focusing exercises, but it works real well for making saccadic eye movements as well. And they come in a distance version, which is larger, and a near version like reading, which is smaller. And you can do these same exercises in either place. And this is kind of what we're after here. We want to start out with just simple lateral movements. And obviously the red circle wouldn't be there, but you just have the patient look back and forth from W to P to W to P and back. And then you might make 10 cycles of those and then go to vertical. Each time you do this, you could change rows so that they look at different letters. But you get the idea, we're moving up and down. You could just as easily have a piece of paper with just the 9, 12, 6, and 9 locations on it. But then once they get good at that, we want to use the return sweep. Notice we're going from the far right to dropping down to the next. And that's what happens in reading. The chief symptom that you'll see with patients that have problems there is they'll skip rows and reread rows. Now we want to make vertical movements with a horizontal component. And you'll go clear across the chart top to bottom, and then do one cycle, and then pause and do another. And this one we call around the world. Here we're incorporating both lateral and vertical movements on the heart chart. And we start this out with a single chart and then move to multiple charts. But it's the first letter all the way around. And then you'll see it. And they're calling these out, by the way. So you have to pay attention too. And there's a little cognitive component to this. They may get a little confused. That's why it's kind of nice to show them this demo so that they know exactly what we're after. But they catch on pretty quick. And we would do the same thing, except with 2 charts. And it would look a little something like this. You start with the 2 heart charts near each other, so you're not making real wide movements. But then when they get good at this, you would actually physically spread the charts further apart. They're taped on the wall. This is great for drivers. They need to make these scanning eye movements and side-to-side eye movements. An alternative way of doing that same exercise, and this is actually the way I do it more often, is we have them look at the first letter on the chart on the left, and then the second on the right, and the third on the left, and the fourth on the right, going back and forth. When they get to the end of one row, we will typically start them at 3 or 4 feet from the chart. Each time they complete a row, take a step back. As they take a step back, 2 things happen. One is that the letters get smaller, so they have to focus harder. But secondly, the amount of distance angle between the 2 charts decreases, so they don't have to move their eyes quite as much, even though the letters are getting smaller. Another way of doing this would be with a video tape that we have. We put on either a computer screen or on a just a regular television set. This is great for at-home therapy. And we start the letters out fairly close to each other. The first time we're just moving eyes. The second time we're making head movements, not moving the eyes. And the third time we let them go natural and do both. Each time the letter flips up, it's getting slightly wider apart. And we want to start, of course, with just lateral movements. Sometimes we concentrate too much on lateral movements. That's where your case history goes in or comes in. We have a lot of patients who have a different lateral separation depending on whether they're looking up or down. So vertical exercises become very important as well, particularly if they have to look up into the rear view mirror and back to the straight ahead, or look to the side and back straight ahead. These are all techniques that help with that driving individual. And these that you see here going right now have a 2-second delay between movements. Then we progress to a 1-second delay. So they have to make those movements faster. And the whole time they're calling out these letters. We all know the value and importance of dual tasking. This is not an exercise that you start with. Obviously, you kind of progress up to some of these things, but you get the idea. And then the last exercise that you'll see come up here in a second requires red-green or red-cyan glasses, because the targets, when they come up on the screen, will be seen by one eye or the other or both. So at this point, you would have them put their red-green glasses on. Well, first do it without the glasses so they get good at it. But you'll see here, these are going to be random presentations. And if we have the red lens over the right eye, every time a red letter comes up, they can only see that with the right eye. The white letters can be seen by either eye, and the cyan letters would be seen only by the left eye. So this sort of ensures that they're using both eyes. This is also a standard therapy that we use for people with lazy eye or amblyopia to make sure that they're not suppressing or shutting off an eye. And you can, use these same exercises for so many things, whether it's the pediatric amblyope or the stroke victim who has a nerve palsy that's either seeing double or shutting off, suppressing one eye. And then we want to progress from those are all saccadic eye movements. Now we're going to talk a little bit about tracking eye movements. And again, we have the same H pattern. This time they're going to follow the finger. Or in your case, you'd probably want to use a better target than your finger. And notice I say 7 positions of gaze. Some people consider the central or straight ahead position as being a primary position of gaze. So we've all done this. We've all moved our finger back and forth, up and down to watch those eye muscles. You want to make sure more than anything that the two eyes are teaming together, that they're moving to the same position like they're hardwired. As one eye, as you move your finger up, if one eye goes up and the other one lags behind, that's indicative of cranial nerve damage or some other trauma. Can be a blowout fracture capturing one of the muscles in the orbit. And just a real quick review, this presentation was not intended to be on eye muscles, but I do want to just remind you, and you can get on YouTube or any of 100 different sources and find these. But this is why we use the H pattern. And if this is your left eye, as we move the things to the left side there and up, we're looking at the inferior oblique. Of course, the medial rectus moves the eye in. The superior oblique is responsible for that downward gaze. And so on. This lets you sort of figure out which muscle might be affected there. The two oblique muscles, by the way, are the ones that are responsible for torquing the eye. You know, the rectus muscles move the eye straight up and straight down, but the inferior and superior oblique actually have to do with a twisting or torquing of the eye. And that's all kind of illustrated here. And then, of course, this helps us diagnose cranial nerve palsies. And again, that's a whole lecture upon itself. But the most common one, if you look over there at the sixth nerve palsy, that's the one that I certainly see the most. And that can be from blood pressure's gone awry, can be sugars too high. There's all kinds of things that can affect that sixth nerve. The other thing to remember is, though, even though we look at that as a lateral problem, sometimes there'll be a slight vertical component in there as well. And then when we get into the eye tracking exercises, we often will use, again, a small binocular vision target with red-green glasses. We start out without the red-green and let them do it with simple high contrast. But we want to do side-to-side movements, very slow and deliberate. And then we want to go up and down. And then we like to do a lot of circular ones, clockwise and counterclockwise. And as they get better at it, we make the circles bigger. When we do this in vision therapy with red-green glasses and 3D targets, we will actually separate the targets so that they have to cross their eyes a little bit while they make these movements, or diverge their eyes while they make these movements. Because in real life, that's what they have to do to compensate for different phorias and convergence insufficiencies. It's like everything else we do, though. You know, you start easy, you start simple, you start with success, and make it slightly more difficult as we go along. And then we want to do the same thing, except the eye's frozen in the head. So instead of making eye movements, we're going to make head movements here. And as an interesting side note, that's one of the things we look for in pediatrics when we do tracking tests or that H test. You'll see a lot of kids that instead of moving their eyes, they'll move their head with everything. And those are typically kids that skip the crawling stage and walk too early. They didn't develop something called tonic neck reflex. So when they follow or track, they tend to use their neck muscles instead of their eye muscles. Now we get into what you're familiar with, and that's, of course, VOR ×1. And here, again, the target size does make a difference. So you want to put a small letter chart, the heart chart will work again, onto the wall in the primary position and do your VOR 1 therapy. Start with small movements and then get more and more movement. In the real world, the typical patient will move their eyes about 17 degrees before they start to make a head movement. So when you're reading, you would, or looking from side to side, if it's within that 17 degrees, you'll probably move your eyes most. And then outside of that, there's a head movement component. Then we get real good at that, of course, and then we'll progress to VOR 2. And here it's very similar to VOR 1. We're moving both head and eyes together. They're moving in equal and opposite directions. But now instead of the target being stationary, as I move my head to the right, the target's going to the left. And that exaggerates and integrates the vestibular and eye movements together. And how do we make these targets more difficult, or how do we make it tougher? We do that by reducing the letter size, by adding a binocular target, the anti-suppression target, and also increasing how much we're moving the head. Notice I suggested starting within 20 degrees because that's where most things are, number one, but also the brain is used to making primarily eye movements in that range and starting with head movements once you get beyond that. And then step 10 is just repeating all of those things that we talked about before, but standing instead of sitting. And you can, with an athlete, you can make it even tougher. You can have them stand on one foot. You can have noise going in the background. You can add all kinds of distractors. And then the next most difficult thing is after getting them doing that just standing is to put them on a balance board or foam so that now we get all of the muscles involved from the ankles up there, of course, and you guys are more of an expert at that than I am, but here we're integrating not only vestibular and vision, but the somatosensory as well. And then if we really want to make it tough, we go to the next step, and that's put them on a ball and have them juggle while they do this. So this is one of my favorite quotes: step with care and great tact, and remember that life's a great balancing act. And that's true in more ways than one. And with the current political environment, I had to put a disclosure down there that the views expressed in this slide are those of the presenter, meaning me, and well, maybe the cat a little bit, but and not necessarily those of any other company. Here's the takeaways for today, and that is that just remember, one of my favorite sayings is there's more division than 20/20. You know, a lot of people think about eyesight and they think, is he 20/20? Well, what 20/20 means is that they can see a small object, but it doesn't mean that they can take that information and make the most use of it. They have to integrate that, understand it. They have to get both eyes working together, and that's where you can help the patient along. And of course, it's crawl, walk, run. We have to start very simple, build upon success, make things more challenging as we go. And where we stop just depends on the patient. If it's an elite athlete, we're going to take them to a very extreme. The 3 I's that I mentioned before, and pun intended, is isolate. In other words, we want to look at each task. We want to improve those tasks that need improving, that have weaknesses. But then we can't stop there. We can't just get their eyes lining up straight. We have to integrate those straight eyes back into the system with vestibular and somatosensory and cognitive and all the other things that happen in the real world. I'd like to thank you for joining us today, and we will hang around for a while to answer questions. Please feel free to submit the questions as we're going along, and we'll try to answer them. We are also starting a blog that if we don't get to all the questions or some questions come in later, we will try to answer those as the weeks progress at that blog site. Again, thank you and stay safe.
Hello.
Hey,
First of all, thank you, Charlie, for this amazing presentation. I'd like to thank everyone that is participating here on our Bertec Knowledge Series. So to kick off this Q&A, it's really nice the link that you left there, Charlie, that we also had people sending questions previously before this webinar. So we will start this Q&A with those questions, and I'll let Charlie go for it.
Well, one of the questions that was submitted ahead of time had to do with toe walking, and that isn't really part of today's presentation, but I wanted to address it because I feel if one person had a question about that, maybe others do too. Toe walking, as you all know, is prevalent in certain populations, particularly cerebral palsy and autism, to mention a few, but it can also be there post-trauma. Optometrists are in a unique position to help with toe walking because we have the ability to use prisms. And if we take a prism and put it base down, and it can be as little as 2 prism diopters, but base down in front of both eyes, it moves the world up for that patient, and their head will actually come up, and amazingly, they will start, in many cases, walking heel to toe. And it's, if not, then we kick them over to you guys for the more standard, OTPT therapies, and in extreme cases, sometimes surgery may be needed or a neurological workup. But for us, we have great success with using base down prism, and it doesn't take much. It's an amazing amount. And then what we try to do in the long run is reduce that prism, maybe go from 2 to 1.5 to 1, try to get rid of it. And we'll work on some visual spatial kinds of things. But toe walking is one of those things that is really greatly affected by yoked prisms. So I encourage you, if you don't have an optometrist, a developmental optometrist, or a neuro-optometrist in your area, find one. You guys, I'm big on multidisciplinary. We need to work together. You guys have your areas of expertise and we have ours, and sometimes those overlap, but that's an opportunity for cooperation, not competition. So, and then the other question that I saw come up quickly was, when are these exercises, saccadic eye movements, indicated? Well, post-concussion, post-trauma, post-stroke, about 50%, 54%, depending on the study you want to quote, of the patients will have eye movement difficulties. And those are often very symptomatic. They'll lose their place when they're reading, they'll see double, all kinds of things that you'll pick up in the case history. I had patient mid-afternoon yesterday, was a 15-year-old girl that had a severe head injury. She came in and it was one of the worst cases of post-traumatic nystagmus that I've seen. And as we're doing these H movements, as she got into different positions of gaze, the nystagmus increased tremendously. And but even in the primary gaze, she had a lot of trouble holding fixation. So she's got a long way to go, but we try to help with those issues. So basically, case history for me dictates a lot of what I do, and we go by symptoms. Fernando, I'll let you kind of read any of the questions that come in or ask me so that people can hear them, and then I can answer them.
Yeah, so I think you already answered the first one there that says indications for the exercises that you were presenting, right? I think that was what you're answering right now. We had Megan asking, actually, would idiopathic toe walkers need more vertical saccades work if they seem to lack gaze stabilization? Patient reports dizziness if walk in normal heel-toe pattern.
Yeah, toe walking is a vertical spatial deficiency. So any of the vertical saccades, any of the vertical fixations are going to help. One of the exercises that we would do is just simply, I call it the cap and the pin. We put a pen in front of them. We have them put the cap back on the pencil or pen and then move it in a different position. We're trying to get them to link up, to integrate the visual motor integration with what they see. And we'll do that with different amounts of yoked prisms, base up and base down primarily. But the main thing is to get some base down prism on there and see if they respond to that, because it's typically a vertical spatial problem there that is easiest handled by using prisms.
We have one more question there.
if VOR starts at 20 degrees, what would be the maximum? What would the maximum progression be? Really, there is no max for the average patient. You know, we live in about 120-degree world for most of what we do. But when you're driving, you actually have between 180 and 200-degree peripheral awareness there. If you're a point guard in the NBA, that better be better than that. So you kind of look at the patient and what the challenge is and the demand, but primarily we like to at least get to 100 to 120 degrees there. The point that I was trying to make with that was that the average person doesn't start to move their head until they get past 20 degrees. And once that head starts to move, then we're invoking the other two systems. We're having a vestibular reinforcement, and then we're having the neck muscles also telling where we're at. So at that point, that's when the integration becomes key.
So the next one, Richard is asking if there are published studies with control groups that support these exercises.
I would have to do a literature search for that. This is something that, you know, we're taught in optometry school from the very beginning, and it's so much a part of our life that I can't think of specific academic studies that have been done, but I will research that, and I'll put any links or published articles up on the blog. We hope to get the blog started as early as next week. Also, for those of you who want to go to the Bertec website and access the blog, I will also try to put a PDF on there of a heart chart, so you can download that and print that out and have those charts for your use.
Yeah, that's good. That's a good link about the blog. So every time we have questions here that we don't have time to answer, or that we need a little bit more research to it, we're trying to answer them on the blog. And don't forget to take a look on our YouTube too. So this presentation will be there later on, and we'll be trying to do that, putting in YouTube, answering questions in the blog, and keep your eye on our Twitter too, because we'll keep posting information there. All that.
Exactly. Yep. I think that wrapped up our questions. Thank you guys so much. It was neat to get one in advance, because then we could, you know, think a little harder on that one and prepare a good answer for you. So don't hesitate to send questions in advance. You can find my email address on the invite. And we're also going to be putting up the pre-registration links on our website. It'll be up within the week. So you should be able to pre-register for any topics that look interesting to you, rather than worry that the invitation is going to hit your spam folder if you're on our email list. So thank you, Dr. Shearer, so much for the wonderful presentation. Thank you, Dr. Santos, for facilitating the Q&A. And so I'll just give you a quick heads up on the lineup, the next two that are upcoming. The next one we have on June 16th is Dr. Cameron Bereen. He's going to present on tests of VOR compensation, like the dynamic visual acuity test and its clinical applications. So that should be interesting. And then on the 30th of June, we have Dr. Nathan Morelli, who's going to present on dual task performance. So we have a couple of vision webinars coming up that actually Charlie is going to co-host for us and facilitate the Q&A. And then we'll go back to some ground force reaction topics and things like that coming up later in the summer. So we're very excited. Please follow us on YouTube, as Dr. Santos mentioned, and Twitter, as he put in the chat. We're Bertec HQ on all of those outlets. Anything?
Sorry, Coach.
No, go ahead.
And feel free to actually get in touch with us and suggest new themes that you like to see here, or a person that you like to see here giving a webinar. And we really appreciate that, to hear from you guys. What do you want to see here, and how can we facilitate and help you to achieve a learning and gathering more knowledge?
Absolutely. Great call out. Thank you both, and thank you all for attending. I hope you have a great rest of your day, and join us next time. Thanks a lot.
Stay safe.
Bye.